Trauma-focused cognitive behavioral therapy, also known as TF-CBT, is a psychotherapy model used for children who have experienced traumatic events in their lifetime. This evidence-based intervention was developed by Anthony Mannarino, Judith Cohen, and Esther Deblinger. Originally, Cohen and Mannarino structured a manual for this approach separate from Deblinger, until 1997, when together they integrated their approaches. In 2006, they published their manual on trauma-focused cognitive behavioral therapy. This intervention was originally developed to address PTSD and other symptoms as a result of sexual abuse. However, the model has since been adapted to treat a broad range of trauma. The primary recipients of trauma-focused cognitive behavioral therapy are children, adolescents, and their parents and/or caregivers. Children ages 3 years old to 18 years old with significant emotional or behavioral difficulties related to one or more traumatic life events are the primary targets for this intervention. These children do not need to meet the DSM-5's criteria of PTSD to receive treatment, but are likely to have symptoms that align with post-traumatic stress disorder. The parents and caregivers or guardians of the child may be involved as long as they were not perpetrators or involved in the abuse. Parents often need support themselves, in addition to the need for skills to support their youth. Trauma-focused cognitive behavioral therapy can be used on both males and females. It can also be used with families of diverse SES, religions, ethnic and racial groups, and can be used in various languages. Trauma-focused CBT is a components-based hybrid treatment model. It incorporates multiple aspects, combining cognitive and behavioral therapy with family therapy. Trauma-focused CBT is a treatment that aims to address thoughts and beliefs related to the trauma the child has experienced. This therapy also provides a supportive environment for children to process their experiences and learn skills to help cope with triggers that could come up. Trauma-focused CBT helps both the child and the caregiver cope with the trauma that has been experienced and teaches adults how to support their children by creating open communication. Parents also receive support in coping with their own emotions. Trauma-focused CBT is intended to be a short-term treatment. Typically, this treatment is provided within a 12 to 16-week period. However, this is dependent on the individual and their situation. When doing trauma-focused CBT, the child and parents work with a specific therapist, both separately and conjoined. Trauma-focused CBT treatment is often divided into 3 categories or phases: the stabilization phase, the trauma narration and processing phase, and the integration and closure phase. When breaking down the trauma-focused CBT model into these 3 phases, it is helpful to refer to the acronym PRACTICE. The P in PRACTICE stands for psychoeducation and parenting skills, which occurs when trauma-focused CBT is first started with a provider. Education about trauma in general and the typical impacts trauma has on the child are provided to the family. The parents are also informed of helpful skills to support their child in managing their behaviors. The R in PRACTICE represents relaxation techniques. Therapists and care providers teach relaxation methods so that when a future trigger occurs, the child will have a toolbox of relaxation skills and know how to emotionally regulate themselves. Some relaxation techniques could include deep breathing or progressive muscle relaxation. The A in PRACTICE stands for effective expression and regulation, which includes identifying possible or potential triggers and then helping the family manage emotional reactions when triggers come up. The C in the PRACTICE acronym represents cognitive coping and processing. This time is spent exploring connections between thoughts, feelings, and behaviors. The CBT triangle I included provides a visual representation of how our thoughts, feelings, and behaviors are all interconnected. Next is trauma narration and processing, which is when the child partakes in exposure exercises through various forms of expression. This can be written, verbal, or creatively. This helps in processing thoughts about trauma and possibly reframing unhelpful thoughts. Then the I in vivo exposure occurs, which is when the child is gradually exposed to trauma reminders, which gives the child an opportunity to practice previously learned skills. According to research, gradual exposure reduces distress associated with these reminders and decreases trauma-related reactions. The C stands for Conjoint Parent and Child Sessions, which is a time dedicated to working on open communication, so the child is eventually able to share their trauma narrative with their parents. Lastly, the E in practice stands for Enhancing Personal Safety and Future Growth. This final step includes safety planning and training for future stressful situations and triggers. The intended outcomes of trauma-focused CBT is to reduce the negative emotional and behavioral symptoms the child is experiencing in response to their traumatic experience or experiences. Trauma-focused CBT provides a child with effective coping skills and provides parents with skills allowing them to support their healing child. Some of the strengths of trauma-focused CBT include the fact that it has the strongest research evidence of any treatment model for traumatized children. This model is also flexible meaning the model can be adapted based on individual situations and allows for therapists to individualize their care based on culture and grieving and mourning practices. Trauma-focused CBT is relatively easy to learn and widely accepted. The parent component is extremely beneficial as it provides parents with knowledge on how to best support their child and also provides a space for some healing that the parents may need. A weakness of trauma-focused CBT is that in order to partake in this intervention, a child must talk directly about their traumatic experience or experiences. Some therapists may not like making a child go back to this time. Trauma-focused CBT is used in a variety of settings, including clinical settings, foster care, military settings, residential treatment facilities, schools, client homes, group homes, hospitals, and individual and group therapy settings.